Ed Mulvey has been a member of our faculty here at Pitt in the Department of Psychiatry for over 35 years. Across his career, he's had over 150 peer-reviewed articles looking at violence in juvenile justice. He's worked with any number of national scientific organizations, including the NIMH, the Surgeon General's Office, the National Science Foundation, and is currently on the Scientific Advisory Board for the U.S. Department of Justice's Office of Justice Programs. He's authored and co-authored some of the most important works we have looking at understanding violence risk. It's my great pleasure to introduce to you my friend and my mentor, Ed Mulvey. Ed.
Okay. Well, good morning. I'm very happy to be here this morning. I appreciate the opportunity to spend some time with you, and we're going to cover a bunch of territory here today. I think that this is an incredibly important topic. I got to admit, I am not an expert on gun violence. I do work on mental illness and violence, and I've done that for a number of years. So I think it should be a stimulating day of discussion, and I do appreciate the opportunity to be here. Before I get too far into the points that I have, I want to give you just a short description of what I want to accomplish here today, okay? I want to give you my impressions of where we are with gun policy and individuals with mental illness based on thinking about the issues of violence and mental illness as most of my career as a researcher. I think I'm going to move through a good bit of information today, and I want to do it pretty quickly sometimes. So I put these things together, so I hope the ideas kind of hang together as I go along. But I want to basically get a few points across. First, it seems to me that using mental illness as a guide for gun policy is a really misdirected idea. Okay, I'll emphasize that. Second, there seems to be some workable, and I would expect more effective alternatives to structuring regulatory policy this way. And third, if these alternatives are adopted, mental health professionals in particular should be prepared to take a more active part in the whole issue than they have to date. So let's get to some of the specific territory I'd like to cover. If I can see this, there we go. Okay. Oh boy, these are like, even with glasses, my eyes, you know. First, I just want to talk about a general overview of the relationship of mental illness and violence and what the research says. And then identify the difficulties with developing a sound policy. Sort of what are the logical problems that are underpinning this issue. And then I identify several emerging strategies, as I mentioned, and then talk about the potential implications of that. Okay, guns and gun violence. Jack had already gone over some of these issues, but I think it's important to keep them in mind as we talk about framing this issue. There's 350 million privately owned firearms in the United States. Okay, it's a high level of penetration of guns that are around in the United States, and the residents of the United States have about 30% of the weapons in the world. Okay. We have approximately 40%, and this is important to remember when we talk about gun violence, about 40% of the firearm transactions are not, federal transactions. These are privately traded weapons. And the U.S. rate of suicide by firearm, as Jack mentioned, is extremely high, and this is a big piece of the problem. And the other issue that I've come to realize in the last few years is that the gun culture is part of the American landscape, and it's here to stay. So the idea that we're just going to wipe it out of the American identity, I think, seems to be a bit naive. Okay, so how's mental illness linked to gun violence at all, right? Mental illness and violence are related to each other in the general population, and this is something we do know something about. Gun violence and mental illness directly related. There's actually very little work on that topic in particular. So if you just go to the idea of, well, what's mental illness? What does mental illness and violence look like in the population? And what you're going to find is that diagnosis and involvement in violence is related. There used to be a time period when it was said, mentally ill are no more violent than anyone else, ever. There's a whole series of epidemiological studies. If you go door to door and you ask people, have you had this bother you, have that bother you, and you figure out what symptoms are there, and then you ask them, have you been involved in violence in the last so many months or so? Yes, they're related, okay? The epidemiological data has been replicated several times. So they are together in the world, but they're there modestly. In other words, the correlation is 0.2. So if 0 is no correlation and 1 is perfect correlation, so that every mentally ill person you found was violent and every violent person you found was mentally ill, that'd be 1. If it's 0, that never occurs at all. This is 0.2, and in social science, that's in the ballpark, but it's not terribly, terribly impressive, okay? The second thing is, and Jack mentioned this directly, most mentally ill people are not violent, and most violence is not done by mentally ill people. I mean, you just take the pie of violence, and a small amount is by people with mental disorders, and you take the sample of mentally ill people, and the greatest proportion of them are not violent at all, okay? This is like driving me crazy. This is like impossible. Can I just move this up here somehow? No. Here, move the table over. Do you mind? Oh. No, if I can just get it close enough to read it, I'm all right. Sorry. That's right. So I had mentioned that most of the pie of violence is not done by mentally ill. Estimates are that somewhere between 4% and 10% of violence in the United States is attributable to people with mental disorders. That's actually, so as somebody put it, if we cured mental illness tonight, we'd still wake up with 96% of the violence in America tomorrow morning. Okay. The most frequent type of violence that discharged patients commit in the studies, that I'm going to go over some of these, only about 3% of that violence, if you just look at that violence, only about 3% of it is related to gun use. It's most commonly shoving, hitting, slapping. It's like the generic violence in the United States. And even in patients who are violent, the symptom changes are not necessarily related to the violent incident. So if you take the incidents in which mentally ill people are involved, only about 12% of them appear to be related by an increased symptomatology at the time. Okay, there are other life characteristics that bring violence about much, much more strongly than does mental health symptomatology. Okay, I want to mention some of the results that have been around for a few years because I think they illustrate some central points. These are from a violence risk assessment study that was funded primarily by the MacArthur Foundation and the National Institute of Mental Health a number of years ago. And in this study, I'll just give you a brief picture of what it does. 1,000 people leaving mental hospitals in 3 different cities, followed for a year, interviewed every 2 months, okay? And also interviewed people who are significant others in their lives during that time period. And asking the basic question of, well, what could we be looking at when someone's in the hospital to help us make a better judgment about whether they might be involved in violence while they're in the community? This has provided a good bit of information about the relationship of mental health disorder when seen in a certain situation and what happens later in the community. And here I'm talking just about community violence. Okay, the first thing that was found by that group really is that violence involving individuals looks a lot like other violence in the community, okay? It's not terribly different. It's not like, 80% of the violence of mentally ill people is throwing bricks at buses. I mean, it isn't that, all right? And if you look at just who violence occurs with, as part of this study, in Pittsburgh, we took 500 people who lived in the communities, the same communities where the people leaving the hospital went and lived. So they were matched for their community factors. And what you find is that most violence is with family members and acquaintances, a lower level of stranger violence. The differences are not terribly different in the group with a mental disorder and those without a mental disorder. And in fact, the stranger violence is, as you see, a little higher in the community group, okay? So they sound the same. And as my colleague Chuck Lids said years ago, he said, this sounds a lot, when we hear these incidents, it sounds a lot like my fight with my wife last night, except it just keeps going on and gets out of control, okay? So it's not distinct entity, okay? And if you then look at this violence, as I mentioned before, this is the study that 3% of the violence in this group involved a gun in some way, okay? Okay. The other thing about this then, though, is that substance use disorders really matter. So when we do these epidemiological studies and you go door to door and you ask people if they have diagnoses, and then you disaggregate that stuff and look at where is that violence related, it's related to the co-occurrence of substance use disorders or the presence of a substance use disorder. And this illustrates the level, the prevalence of a sample, of that sample that I'm talking about, those people in Pittsburgh who left the hospitals here, who went back to the community. And those 500 people, remember I said, who didn't have mental disorders, who were in the community, they're that white bar on the left up there. So their prevalence rate's hovering somewhere around 5%. Now, if the other 3 bars are the patient sample broken down into 3 groups. Those people with just serious mental disorders, that's the yellow bar, so they get mainly depression and schizophrenia. The other one is people who have a serious mental disorder and a co-occurring substance disorder, that's the red bar, so their prevalence is higher. And the last group is people with less serious mental disorders, non-axis 1, as we would in the old days say, and a substance use disorder. What this is just showing is that the prevalence of that violence that you observe in people with diagnoses is occurring in people with co-occurring substance use disorders. The difference between that white bar and the yellow bar, the community sample, and those people just with mental disorders and no co-occurring disorders, statistically insignificant, okay? We're hovering around 5% in both groups, okay? Now, the thing is, if you take those same groups, and fortunately they're the same colors in this one, and you follow them over that 1-year time, what you find is there's little fluctuation at all in that lower yellow group, the groups with just the disorder and no co-occurring groups, and yet the differences are really high, and for the first time out of the hospital for those people with co-occurring disorders, all right? So they're at very high risk when they leave the hospital, which actually is different than we expected. We thought they would kind of be low. You go into the hospital, you get a little better, and then you might ramp up again. But it's the other way around. When people come out, they're at high risk because they're going back to the same situations oftentimes, the same problems that brought them in the hospital, and the clinical episode is probably longer than we keep them for a hospital stay with short hospital stays. So people are at risk at times, particularly people with substance use disorders and co-occurring problems. Okay, so that's one thing. Is it related? Yes. Is it mental illness? Doesn't look like it. It looks like just the mental illness itself doesn't differentiate a case as having a problem, okay, in terms of continued violence. And this is probably one of the most extensive studies that's been done on this topic. So that's one piece. Now, the other reason I have this reservation about the idea of mental illness as an indicator is another study that we did where we instead went in and said, okay, let's go into the emergency room and find the psychiatric emergency room and profile and find people with repeated violence, people who have a lot of involvement in violence in the past, and they have substance use disorder problems, right? So we get 134 of these people, and we decide, well, we can't interview them every 2 months. That's not going to give us enough fine resolution on what happens over time. So we interview them every week for 6 months. Excuse me. So as we interview them for 6 months, you then can get a pattern of how things change over time. Are they drinking a lot more this month and then it goes down? Are they, having unemployment issues here or not? So you can track a number of things over time. And what we find in there really is that this amount of alcohol and drug use also predicts violence in close proximity to when you elevate your use of drugs or alcohol. So first you got the major disorder category, and that's different. And then you say, okay, well, let's look at people closely over time who are likely to be violent. And we find, yes, when the alcohol and drug use goes up, the likelihood of violence goes up. And this is a table. I think I had a warning on the first slide that there was going to be data involved. So whenever you're at a law school, you always have to be very careful about numbers because people freak out. They went into law for a reason. They don't like numbers. And so this is a table on the left side in the yellow. Remember, we've got these weekly interviews. Well, when we can do these weekly interviews, we can say, okay, this is Tuesday. Where did you drink yesterday? How about Sunday? Oh, yeah, Sunday was my brother's. Oh, did you? Yeah, we hung out for a day. We were watching a game, and we got really drunk, blah, blah, blah. Okay, so you can go back by day about a week where people can recall how much they drank over the last week. That then gives you not weekly observations, that then gives you daily observations of drinking and violence. And people can pinpoint when violent incidents occur. That was last Wednesday, such and such. So now you got all these observations over 6 months period. Then you take one day and you look at it compared to the next day. So you basically say, if you were drinking heavy on Wednesday, did you have violence on Thursday, right? Or were you drinking heavy? This is the odds. And odds of 1 means no relationship. You're just as likely as unlikely to do it the next day. What you have here is, in yellow, the day before, all the days before, compared to the days after in that long series of daily observations. So what you notice, first of all, is something along these diagonals, these big numbers. So serious violence on one day predicts the involvement in serious violence on the next day. People are 5 times more likely to be violent the next day. So if I'm violent on a Tuesday, Wednesday, I'm at 5 times the risk on Wednesday to be violent, okay? Now what's interesting is that's also true of alcohol use. It's also true of marijuana use and other drug use, right? So one thing that tells you really basically about these behaviors is we're trying to pin things like gun violence or any other violence in a behavior is this simple thing. Most of these cases are like this actual case out of there. Those lines up and down indicate a violent incident for that person, all right? The dash across each one of those is a day in that observation period. More of these people are like case 8, where it clusters, than they're gonna be like case 2080, where they're just scattered randomly all over the place, okay? So what this illustrates is these behaviors occur so that if you find somebody who's violent, that's a good time to find them, right? It means because it's probably gonna cluster around. If you find somebody using a lot of drugs, that's a good time to try to figure out whether they're gonna be involved in drugs the next 2 or 3 or 4 days. It looks like that's exactly the case. They are gonna cluster in those behaviors. So, let's go back to this table again. We notice the diagonals. That's what the diagonals tell us. Now the problem are these two, right? Let's look at this for alcohol to serious violence the next day. 2.4 times more likely. If I drink on Wednesday, I'm 2.4 times more likely to be violent on Thursday, right? Unfortunately, if I have serious violence on Wednesday, I'm 1.9 times more likely to be drinking on the next day, okay? So I don't know whether am I being violent and then drinking? Am I always drinking and what's the difference? It doesn't predict violence at all, but there's some relationship here. I just can't sort out 1.9 and 2.4 doesn't look terribly impressive or different to me. Okay, so here we're gonna, bear with me because I'm gonna explain this conceptually and trust, people like me do statistics for a living, so if anybody wants to talk about it, I'd be glad to, but trust me on this one, okay? You create a model that looks like this, and when I say a model, here's what I mean. You say, this is what I think's going on in these data, right? I think that there are some relationships in these data that I wanna put down in a statistical model. And then I want to take that model and I want to see whether it fits the data or not. So the data is going to tell me whether somebody was violent or not, whether they drank or not over the course of all these daily observations. And I believe that violence at time t, on the right up there, okay, is going to be predicted by whether the person was violent the day before, and it's going to be predicted by whether they were violent 2 days before, okay? I think there's some relationship that if somebody commits violence on Wednesday, they're going to commit violence on Thursday and Friday, right? So I draw this arrow between t-1 or t-2 to t-1 to t, right? Somehow violence predicts violence predicts violence. You can see where the rest of these arrows go. I also think that if you're drinking 2 days ago, you're more likely to be drinking at the end, blah, 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 right? And I also know that if you're violent on one day, you're more likely to be drinking that day, right? So that's that curved arrow. I'm saying all these things are related, and is that by chance? What I'm saying is I'm going to take this model, I'm going to put it on the data, and do any of these appear to be more than just chance? And that's what you're testing. The ones you're interested in are these. Does alcohol drive violence? Or the ones going the other way, the light ones, does violence drive alcohol? Because that's where I was stuck with that 1.9 and that 2.4. What's the difference? This is a way to test that. I account for all those other relationships, and then I see whether the one I'm interested in really is more than you would expect by chance. And what you find is, yes, it is. Alcohol drives the violence. Alcohol drives the violence. The violence doesn't drive the alcohol, okay? From day to day. Now, we take all the symptoms, because we also have symptom measures, right? And we test the symptom measures, and what you find is none of the symptoms predict. When I take a model like that, testing symptoms from 1 week to the next week, because we can't get daily symptoms. I can't ask you how depressed you were last Tuesday, but I can tell you how depressed you are when I see you, right? So you can do this by week. All the symptoms don't drive. There's only one symptom that drives it, and that's hostility. It's basically anger. Do you want to break things? Do you want to hurt people? Do you want to do blah, 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 all right? It's that sort of thing. Psychoticism, depression, all the other scales, they can change around, but those levels do not seem to be related to violence when tested in this fashion. And again, we got the big groups, then we got the people day to day of people who are likely to be violent. Okay, all right. So violence can one day predicts the next. Alcohol predicts violence, not the other way around. Also, when we tested multiple substances, if you do violence and other drugs, alcohol and other drugs, you're much more likely to be violent. And the only real symptom that comes out is hostility and anger. Okay. Nonetheless, there's a belief in this strong association between serious mental health disorders and violence. And it persists. This is a kind of a long quote that you can read that was out a number of years ago. And it talks about a period in the 60s and 70s when mental illness was romanticized or celebrated in films. It goes through the whole thing, and then it basically says, but now there's all of these crazy people out there, right? And I think, as Jack just pointed up earlier, what this means is that many polls, 60% of Americans believe that people with schizophrenia are likely or very likely to be violent, okay? Despite whatever you can find in the research, there is still this very strong belief culturally. So you say, okay, so why is this going to matter at all? Well, I think it matters because it creates a regulatory environment where the old axiom in legal policy, hard cases and great cases make bad law. And that comes from a case, the Northern Securities case years ago in the early 1900s, when Oliver Wendell Holmes noted, great cases like hard cases make bad law. For great cases are called great, not by reason of their importance in shaping the law of the future, but because of some accident of immediate, overwhelming interest which appeals to the feelings and distorts the judgment. And I think that's the reason this matters, okay? So have we done this with gun policy? This is what's happening with gun policy. I think we're kind of making bad law from hard cases. And it's useful to just kind of get a general outline. I'm sure people here know much more about this than I do, but the federal firearms policy really says that gun ownership, the recent decisions are that gun ownership is an individual right. So we're allowed to have guns, all right? It's not a state's issue, it's an individual rights issue. But at the same time, those decisions say it's not unlimited, meaning that there can be regulatory practices put upon people's ownership of guns, and it specifically talks about mentally ill individuals as a group that it just seems, of course, totally reasonable that they shouldn't be allowed to have guns. The problem is not the guns, the way this logic goes. It's instead how to best identify people who should not have access to guns. So the decisions really kind of flip the logic in a way of, yeah, there are a lot of guns, but it's an individual right. So the issue for the law is to try to figure out, well, how to keep those guns out of the hands of people who shouldn't have them. And they talk about the mentally ill as part of the federal provision of what constitutes a mentally ill individual. And the term there is, I don't know where they keep sticking this in the legislation, but a mental defective, which is interesting. I'm not sure what to make of that. Anyway, but regulation based on actuarial prediction of individual behavior is basically what we're doing here. And I just want to clear up for people who don't use these terms very much. Actuarial approach, it's group-based, algorithmic. It's sort of the thing your insurance company does to determine your driving rates. And it's the same indicator information is considered for every person. You've got one model that fits everybody in the group. And there's some consistent measure for putting this stuff together. The clinical approach, you can think of these as two poles. The other clinical approach can be called individualistic, idiographic, okay? In other words, what you're doing here is you're taking potential range of relevant factors and you're deciding which ones fit this case. And you're doing each case individually. And supposedly it would be an integrative view. Now, people have argued about this for a long time. This is an old debate, actuarial versus clinical, what do you do, who's better? It's really kind of a red herring debate in a lot of ways. But it's gone on in suicide and in job success and a lot of other things. In general, you find that actuarial approaches outperform clinical approaches in the long run, okay? And that's an important thing, because what we got here is a basic actuarial thing, mentally ill, gun violence, right? Now, there's a few flawed logics in this. One is that post-diction is not prediction, all right? As already mentioned, this idea that mental health problems are linked to gun violence is largely post-dictive. We see a lot of rampage killings and we say, anybody who does that must have a mental health problem, therefore mental health problems are it. But the conditional predictions, if you have this, then that, is never the same going backwards as it is coming forwards, okay? So let's say 60% of cocaine users start on marijuana, all right? You go out and look at cocaine users. And then you say 75% of marijuana users drank mother's milk, okay? But that doesn't necessarily mean that mother's milk leads to cocaine use, all right? So there's just this going backwards and going forwards. When you think of it, it doesn't make much sense, yet that's a lot of what we're doing in these situations, okay? The second thing is a confident prediction doesn't mean a better prediction. There's a whole body of research on confidence levels. Confidence is only mildly correlated with the actual accuracy of the prediction. So when people say, oh, but these people are sure in this case, or this one knows that, or this class of people, blah, 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 right? That is not held up in the literature very strongly at all. And I think probably one of the best examples of that was General John Sedgwick at the Battle of Spotsylvania, who was the highest-ranking Union soldier to be killed at the war at that point, when his last words were, "They couldn't hit an elephant at this distance," and that was the last thing he said. He was confident. Okay, the last thing is prediction is not explanation. And I think this is really important to remember. I can put a lot of things in an actuarial model and get really good prediction. That doesn't mean I've explained how that behavior unfolds, okay? Actuarial prediction outperforms clinical judgment, and yet there's an old equation at the bottom, if you ever want to care about an old psychology equation from Kurt Lewin. It just says basically behavior is a function of person and environment, all right? So while actuarial predictors do well, there's a couple things you have to realize about them. All they need are risk markers. They need something that happens at the same time and in a strong way as to when the violence occurs. They don't need risk factors. Risk factors are, if I change that thing, will that reduce the violence, all right? Actuarial is all about markers. It's all just like, hey, I found this. The number of garbage cans in Minneapolis might be correlated to something. But hey, if it works, let's use it, So that's the sort of thing you have to realize is there are risk factors and risk markers. Actuarial prediction is all risk markers. It doesn't have an explanatory model in there. It's just got a statistical relationship in there. That leads us to the other thing that we talk about is risk status and risk state. So while I've got these actuarial models, I can put them together and I can find high-risk cases. Now, those high-risk cases don't stay high-risk cases every day. People who are violent don't get up in the morning and say, hey, I'm going to go out and be violent today. This would be a great day to be violent. Things happen to people. Things change. You lose your job. You have a fight. You get drunk. Who knows, right? But that means that you could have a high-risk status, but your risk state is going to go up and down and up and down. So it's very important that we consider the idea of risk status and risk state together. This is putting that actuarial model and another sort of conditional model together. So where could we be headed if we start thinking this way? If we take this as reality, the mental illness has a very low relationship, and that we've got to consider the problem in these other terms. What's happened is regulatory policy in this area has not kept up with basic behavioral health practice. Behavioral health has gone here. They've realized the prediction isn't the issue, management is the issue. What are we going to do about it, and how are we going to monitor people, and how are we going to focus our resources where it makes the most sense? And there is some method for integrated identification and management. There's structured methods to identify high-risk groups and provisions to monitor and react to changes in a person's situation. That's sort of the ideal model. It isn't actuarial versus clinical. It's how do we get these two together? And I think we're doing this in mental health care. Now, I also think there are models that are going to be important for thinking about firearm policy that have been proposed by a group, this consortium on risk-based firearm policy. And they have come up with the idea of prohibiting firearms according to really what are much better predictors than mental illness. And you can see what a lot of them are up here. They're saying mental illness is so broad, as Jack mentioned. There are other criteria we can use, such as a series of violent misdemeanors, a series of DUI things. We're back to the substance use. We're back to the prior behavior. These are things that actually have demonstrated relationships to gun misuse. Then you make the expanded disqualification contingent about that it can be reinstated. This gets back to the risk marker and risk state. We have ways to do risk markers. Well, let's monitor the risk state phenomenon. We monitor the risk state phenomenon. Somebody has a horrible time in their life where they're at high risk for committing gun violence. 3-5 years later, maybe their life is totally different. Well, if there's a procedure to reinstate that right, it's not taking it away for life, like our current policy is, deciding if you meet a particular class, you therefore go out of that. And then you enact a presumptive removal laws and reinstatement laws. These laws have been passed, I believe, in Connecticut, Indiana, and California. And they're talked about as risk-based preemptive gun removal laws. They require probable cause, that there's something out there that makes an order, a warrant for taking action viable. There's some significant risk. We're not talking about just anything. We're talking about actual hurting somebody with a gun. And there's a provision in there for an opportunity for rights restoration. All right, so it isn't a lifetime ban. This actually, I think, maps a whole lot more onto what we have in terms of understanding how some of these markers and risk factors might be related to gun use. The last thing I just want to mention, as I mentioned before, is if this happens, if these things become more popular, and I would argue they make a heck of a lot more common sense and empirical sense than what we're doing currently, mental health professionals better be ready because it's very easy to oftentimes say, oh, it's a terrible problem, and we know more, and we know so much about that. Well, what's going to happen is they're going to have an expanded clinical role in asking about gun presence in homes and precautions that can or might be taken, expanded role in prevention activities, and an expanded legal system involvement with identification of individuals about when it should be removed, when it should be reinstated, under what conditions, what should be monitored, those sorts of things. So this kind of forces that mental health legal interface together closer, but it seems to make a whole lot more sense empirically to me as a researcher than what we currently have is just a blanket banning for a very long time period, which doesn't seem to map on what we know about any relationship between mental health problems and violence. So that's sort of where I've come to over time in this. So appreciate it.
So I do have a question. What's the research study on this topic that you most want to see done? That you most want to see funded?
Yeah, done and funded go together, yeah. The most I would like to see done is actually a demonstration of the fact that we can put a system together with actual gun use. And that's a very, very tough study to do because you've got to track when people use guns and how they use them. And I'm not sure it could ever be done, but if I had an ideal one, it would be to actually use the dependent variable, the actual behavior of interest is gun use. And I'd like to see something done with gun use because right now we have a lot of proxies. And I think self-report is good, but might or might not be sufficient.
I'll get closer to the mic as we get that one working. Since the likelihood of violence is greater immediately following hospital release, is there any movement to facilitate letting families or police know more about an impending release?
I don't, you would probably be better suited to answer that question because you do much more of the clinical work. I don't have a real good vision into that. I do think that for families in particular, we've become particularly interested in this problem now, is that families are really always kind of the first responders to incidents, to violent incidents, and yet they receive very little guidance about what they can do that's reasonable or might be helpful or might make things worse. We're interested in doing some research on that area right now. And I think that the idea of not being able to get information about family members when we know that family members are one of the highest likelihood of being involved in the incident at the time, and they're likely to be there or see it ramp up, and they could maybe do something about it. That's a major gap in this area. I don't think we've done much of anything with families other than oftentimes to pathologize them in ways and not to think about them as a resource. And I think in many cases they're a resource, in many cases they aren't. But nobody knows whether it's 20% where they're not or 80% where they're not, because we don't really talk to them very much about this stuff. We'd rather put them in a clinical box and move on.
So, one last question. Does the interviewing process change the behavior?
Yeah, that's interesting. We were worried about that when we started doing these studies initially. And so we kept measures of therapeutic alliance and what the person thought about the relationship to the interviewer. And there are no doubt, when we were doing weekly interviews of individuals, we saw those people's lives and knew much more about them than the mental health professionals who were working with them. There's no doubt about that. And they spent more time because we visited them in their homes, and we would visit them anywhere they wanted to be. So it doesn't change the behavior. At least all our analyses were that none of the stuff that indicated the relationship quality was related at all to the outcome variables. Now, if it did anything, it might have suppressed the violence somewhat, we think. And so that's sort of our ethical door that we're comfortable with, that talking to somebody, if I was going to do a cognitive behavioral therapy session with people about violence, first thing I would do is to talk to them about their violence and and can they think about it in logical terms, and that's what we do. So we didn't see that as probably raising it. We saw, if anything, it would allow people to be more introspective about it. But at the same time, we don't have a clear answer to that, but the analysis we've done we don't think it did.
Ed?
Okay, great.
Thank you,
Jack.
sir.
Appreciate it.